Cystic lung disease with you today. I'm an assistant professor of radiology and medicine in the chest radiology division at the University of Kentucky, and as you can see from my other titles, I also have an informatics and IT role as well. I do have these disclosures, book royalties from some previously published work. So we're going to concentrate today on diffuse lung diseases that can present as a primary cystic abnormality on lung CT. So let's start off with a simple definition. Cysts are thin-walled, well-defined air-containing lesions. So that definition separates them from things that mimic cystic lung disease, like emphysema, cystic bronchiectasis, cavitary nodules, and honeycombing. When you see a diffuse lung disease that is a primary cystic lung abnormality, you should actually be pretty excited because they don't occur that frequently and they're always interesting, but really there's a relatively short differential of things that present like that. And it's been shown that you can actually, in most cases, give a fairly confident diagnosis and be correct about what the actual cystic lung disease is, especially if you have a little bit of clinical context. So take a look at these two images. On the left, we have a true cystic lung disease. These are well-defined air spaces with thin walls. Contrast that with the image on the right, where you see a classic case of central lobular emphysema. So in this case, you might argue that there are some walls. In reality, those are just pulmonary vessels and areas of interstitium. So they're not completely encased the same way the true cystic abnormality is on the left. Additionally, in this pattern of central lobular emphysema, you can actually see small little dots at the center of the secondary pulmonary lobules that represents the central lobular artery running in the center of the secondary pulmonary lobule. You see that with emphysema, but you do not see that with a true cystic lung disease. Here's another example, cystic bronchiectasis as compared to true cystic lung disease again. Again, look for that bronchiectasis to connect back up to the more central airway to be a clue that you're not dealing with a true lung disease that is cystic. Instead, you're dealing with an airway abnormality causing bronchiectasis. So we want to focus on these lung diseases, again, the ones that present with cysts as the primary lung abnormality. The first three are far and away the most common ones: lymphangioliomyomatosis, pulmonary Langerhans cell histiocytosis, and lymphoid interstitial pneumonia, most commonly abbreviated as LIP. The others are considerably more rare: Birt-Hogg-Dubé neurofibromatosis, amyloid, light chain deposition disease, and cystic metastasis. But we'll go through all of these today. So we'll start off with lymphangioliomyomatosis. So this is related to a proliferation of smooth muscle cells in the bronchioles, small vessels, and lymphatics. And if you remember that those areas are the ones where the smooth muscle is proliferating, then you can easily remember all the findings that you'll be wanting to remember when you see a given case. This is related to what's called the perivascular epithelioid cell tumor, the so-called PEComa, which is related to the angiomyolipomas. Now, with the exception of LAM and angiomyolipomas, PEComas themselves outside of those organ systems are actually extraordinarily rare, but that is the underlying pathologic abnormality associated with LAM. So because the smooth muscle cell proliferates in these areas, that's what leads to obstruction of the bronchioles, giving you a cystic lung disease, obstruction of the lymphatics, leading to the lymphatic abnormalities that we'll discuss, and the blood vessels as well, leading to some of those abnormalities. So it exists in two primary forms: a sporadic form, but then also a form related to tuberous sclerosis complex. So the sporadic form is essentially a disease of young women. The sporadic form does not occur in young men. So if you're seeing a case of possible LAM, and it's in a male, they should have tuberous sclerosis complex. The sporadic form occurs in about 50,000 patients worldwide, but the tuberous sclerosis related complex is actually considerably more common. But only 30% or so of people who have tuberous sclerosis actually have pulmonary LAM. The symptoms, relatively non-specific, progressive areas, progressive cough, progressive dyspnea, but they have a very high lifetime pneumothorax risk of upwards of 80%. And pneumothorax is frequently the presenting abnormality that brings them to the emergency room, prompts some imaging, and then we discover that they have an underlying cystic lung disease. That's because pneumothorax is frequently the initial presenting symptoms. It frequently takes several years before a final diagnosis is made. And these patients do have an elevated vascular endothelial growth factor. Treatment, progesterone, tamoxifen, anti-estrogen agents, and other corresponding things, radiotherapy potentially, oophorectomy. The overall outcome is fairly variable, but slow progression is fairly typical, and that can lead to the need for lung transplant, but the lung can still have recurrence even after transplant. So what do we see on imaging? We see diffuse thin-walled cysts, and I mean diffuse. They are distributed diffusely through the lungs and the craniocaudal plane. They're fairly regular in shape. They're pretty looking cysts, very well defined, very regular, very symmetric. They can get progressively larger as the disease progresses, and sometimes you can actually see small discrete nodules or ground glass opacities. Now those small nodules or ground glass opacities aren't actually related to the smooth muscle proliferation that causes the cystic lung disease. Instead, those small nodules are related to pneumocyte hyperplasia, but that's still not commonly seen in the setting of LAM, but you can see that sometimes. Because of lymphatic involvement, you can get adenopathy and you can get chylous effusions or chylous collections anywhere else in the body. And again, the pneumothorax rate in these patients is very high. So here's a case. On CT, axial, and coronal reformats, we see very pretty, discrete, thin-walled pulmonary cysts. So these cysts have discrete, small, thin walls, right? These are not areas of cavitation that are thick and irregular. These are nice, clean, relatively regular-sized, thin cysts. In the craniocaudal plane, on the coronal, we see they're diffusely distributed throughout the lung parenchyma. These are classic LAM appearing cysts. Here's another example, somewhat smaller cysts, but again, and if you're going through this case quickly, you may just think that this is central alveolar emphysema. But again, unlike emphysema, these lucencies actually have small, discrete, thin walls surrounding them. So this was another case of LAM, and notice this patient had presented with a pneumothorax as there's a chest tube in the left lung. Here's yet another case of LAM, slightly larger cysts than we were seeing in the prior example, but diffusely distributed, clean, pristine, nice, thin-looking cysts. Again, note the pneumothorax in this patient was the presenting symptom for this patient. Chylous effusions occur, but you can also get chylous ascites, as this patient had developed due to obstruction of the lymphatic system in the abdomen of this patient. Remember, there's an association with angiomyolipomas in this patient. The renal ones are the ones we talk about frequently, but they can occur in multiple different organ systems, like the retroperitoneum in this patient. Here's another example where the patient had developed hepatic angiomyolipomas as well, small little hypodensities inside the liver parenchyma that are fat attenuation. So one of the things that I was confused about when I was first learning about LAM was the relationship between the sporadic LAM form and the tuberous sclerosis related form. Either form can end up developing angiomyolipomas, but there's a much greater likelihood of those angiomyolipomas in the tuberous sclerosis complex related LAM than in the sporadic form. So if you see very large angiomyolipomas, or if you see multiple angiomyolipomas, then the likelihood that that patient has tuberous sclerosis related LAM as opposed to the sporadic LAM is higher. And there's the entire rest of the autosomal dominant spectrum of tuberous sclerosis, to include the cardiac rhabdomyomas, the retinal phacomas, and then the mental findings as well, seizures, mental retardation, and then the skin findings of adenoma sebaceum. And it's important to remember those renal abnormalities, the angiomyolipomas, and the skin abnormality as adenoma sebaceum, because that helps us distinguish this from one of the other cystic lung diseases that we'll discuss later, Burtag-Debay. So the next cystic lung disease we want to talk about is Langerhans-cell histiocytosis. Now, there are a variety of forms of Langerhans-cell histiocytosis, but most of those, the more systemic ones, have very infrequent pulmonary involvement. We instead want to focus on pulmonary Langerhans histiocytosis, which is a proliferation of Langerhans cells in the bronchiolar subendothelium that results in granuloma formation and destruction of the bronchi. It most frequently occurs in relatively young adults. There's a slight male predilection, but that's probably related to the fact that this is very highly associated with smoking. So almost all patients with pulmonary Langerhans-cell histiocytosis will be smokers, and there's a slight male predominance of smokers compared to women, and that's thought to account for the slight male predominance of PLCH relative to women. It's probably an uncontrolled immune reaction to some antigen in cigarette smoke, but we don't know exactly what that antigen is. Again, these patients present with relatively nonspecific symptoms of cough and dyspnea. The lifetime pneumothorax risk is, again, pretty high, but not nearly as high as it is in LAM. They may experience weight loss, fever, night sweats, and anorexia, but overall, most of their findings are fairly nonspecific. Treatment, smoking cessation is key. Steroids and some chemotherapeutic agents can be utilized, but to various effects. There's no consensus about what true best practice is for treating PLCH, aside from the fact that they should stop smoking. Overall, about half of patients will have their disease stabilize, but unfortunately about 25% will actually progress despite smoking cessation and despite treatment. When they do progress, they can really develop pretty profound pulmonary hypertension that may require lung transplantation or even heart-lung transplantation, and the disease occurs in upwards of 20% of patients after transplant. So on pathology, what do we see? We see increased cystic spaces on the low power imaging, increased interstitial thickening, and increased cellularity. And when you zoom in, you see that that interstitial thickening and cellularity is actually pulmonary Langerhans cell infiltration. And these Langerhans cells have developed inside of the interstitium. And then those Langerhans cells stain positive on immunohistochemistry for CD1A. So on imaging, early in the disease course, we see small nodules. They tend to be upper lung predominant with a slight predilection to be centrolobular in distribution, but they spare the costophrenic angles and they spare the anterior right middle lobe and the lingular tip. Mid in the disease course, those nodules will progressively cavitate, and it's the combination of small nodules and cavitary nodules that often will prompt one to think about this disease. But late in the disease course, the nodules go away and you end up with bizarre and irregular looking cysts. And it's because of that late disease appearance that we included in this talk on cystic lung disease. So here's an example. Early in the disease course, this is a single view of a frontal chest x-ray, and there's a very subtle, mild nodularity in the upper lungs. If you're going fast, you may even call this examination normal, but there's a very slight, subtle abnormality in the upper lungs, small little nodules. On CT, we see the abnormality much better. Again, a few sparse little discrete nodules. There's a little bit of emphysema telling you that this isn't a smoker, and this turned out to be PLCH. But as the disease progresses, you see stuff like this, where you see small discrete nodules again, but you see now some areas of nodular cavitation but then also small little discrete cysts. But notice the quality of these cysts is significantly different than the lamb case that we saw earlier. These are much more irregular, much more bizarrely shaped than the nice, clean, rounded, and slightly oval looking cysts that we saw with lamb. As the disease progresses further, you end up with a pure, bizarre, cystic looking abnormality. Now, even late in the disease course, these diseases will still be upper lung predominant and will still spare the contraphrenic angles. But again, it's this late disease course that we don't want to confuse with something like lamb. The cysts that we see here are really quite different. So again, upper lung predominant, diffuse cystic abnormality. There is some emphysema here because remember, these patients are smokers, but a lot of these are not holes in the lung and are instead actual small little cysts with discrete walls. Now notice, even in this very advanced case of PLCH, there is still contraphrenic angle sparing. We can see that quite vividly even on anatomic specimen where there is upper lung predominant cystic abnormality, but then the disease process really spares the right middle lobe tip and the lingular and the lower lobe subpleural lung. So here's an example again of how this disease can progress over time, from nodular disease earlier in the disease course to a really severe cystic lung abnormality later in the disease course. There was 3 years between this these two x-rays in this single patient. This is the same patient separated in time by 3 years. Here's another example of the same thing where you see upper lung nodularity, cystic abnormality and cavitations in association, and then later in the disease course those nodules resolve and you're left with a pure cystic abnormality. So that brings us to another disease, lymphocytic interstitial pneumonia, where the alveolar interstitium is permeated by these polyclonal lymphocytes and plasma cells. The true idiopathic LIP is extremely rare, and it's classified now in the rare idiopathic interstitial pneumonias after they reclassified the interstitial disease, the idiopathic interstitial pneumonia classification by the ATS guidelines. So it's much more frequently associated with an underlying Sjogren's syndrome. There are some other causes, but those other causes are really quite rare as well. Things like Castleman syndrome and some autoimmune thyroid disease, bone marrow transplantation as well can lead to that. Originally, they thought that LIP might be a precursor or could sometimes undergo malignant transformation to lymphoma. That's no longer thought to be the case. We now believe that lymphocytic interstitial pneumonia does not convert or malignantly transform into lymphoma. And instead, when those cases were reanalyzed, they were lymphoma to begin with. But keep in mind that there's such a high association of this disease with Sjogren's syndrome, and Sjogren's syndrome patients are at a very high risk for lymphoma as well. So what do we see on imaging? Originally, again, described as lower lung predominant ground glass opacities, sometimes with some central lobular nodules or even tree and bud opacity, and possibly a minor degree of fibrosis. But it's been a more recent experience, and my own personal experience as well, that that LIP can present entirely as a cystic lung disease, and that occurs in upwards of 80% of patients. Now, the lung cysts themselves can look very similar to the cysts that you see in lamb, as we'll see in just a second, but the distribution is different in the setting of LIP. So it tends to be, instead of diffuse, as in lamb, lower lung predominant in LIP, and they have a somewhat unique perivascular distribution as well, and I'll show you what I mean by that. So here, there are very clean, nice-looking, well-circumscribed, thin-walled cysts. You might argue that, yes, this looks just like the lamb cases that I showed you earlier. But if we look in the craniocaudal plane, there is a slight lower lung predominance here. And additionally, Some of these have a relation to the adjacent pulmonary arteries that run next to them, and that's that so-called pulmonary perivascular distribution to these cysts. So you'll frequently see these vessels splayed or the cyst enveloping the adjacent pulmonary vasculature, and that's that perivascular distribution. So these cysts are slightly lower lung predominant, and they've got that perivascular quality that helps separate them from LAM. But in subtle, more mild cases, separating out LAM from LIP based entirely on imaging can be difficult. Here's again a very mild case of a cystic lung disease. Discrete small little cysts that individually look very similar to cases of LAM, but on the coronal, I think you can agree that there is a slight lower lung predominance here as opposed to a more diffuse distribution of these cysts, suggesting that this is more likely LIP than LAM. And additionally here you also again see some of these cysts butting right up against the adjacent vasculature, again kind of suggesting that perivascular distribution. Here's another example, lower lung predominant, well-defined, small regular cysts, thin-walled cysts, again with that somewhat perivascular distribution. Again, note the relation next to some of these small vessels. Now remember, not all cases of LIP are cystic, and the ones that are not cystic tend, at least in my experience, to not show cysts at all, and instead you see this sort of ground glass abnormality that I just want to remind us that not all LIP is cystic like that, even though, at least in my experience, the majority is. So that brings us into some fairly rare diseases at this point, one of which is referred to as Birt-Hogg-Dubé. Now, this is also an autosomal dominant abnormality like tuberous sclerosis complex, and it also involves skin findings and renal tumors. So in that sense, it almost mimics some of the abnormalities that we experience with LAM-related cases, but the exact abnormalities that occur are different. So in Birt-Hogg-Dubé, we actually get fibrofolliculomas instead of adenoma sebaceum. And the renal tumors that we get, instead of angiomyolipomas in LAM, we get renal cell carcinomas and we get oncocytomas in Birt-Hogg-Dubé. The pulmonary cysts we get are thin-walled again, but lower lung predominant, unlike LAM, which is more diffuse. So the ones in Birt-Hogg-Dubé are lower lung predominant, and they tend to be more elongated and occur along the subpleural lung and along the mediastinum. So the shape and distribution, again, of these cysts can help us distinguish them from the ones found in LAM. So here's an example of that. We see an elongated cyst occurring right along the fissure. And again, these are lower lung predominant. So individually, these cysts look, again, similar to the ones you see in LAM because they're nice, clean, well-defined, very thin-walled. They're not bizarre looking the way you would see in PLCH. But in this case, they're lower lung predominant, and we see them in this elongated form, and we see them occur more along the mediastinum and occur more along the pleura. So that helps distinguish them from pulmonary cysts found in LAM. Again, highlighting that subpleural positioning of some of these elongated cysts, and cysts occurring along the mediastinum, lower lung predominant in the craniocaudal plane compared to more diffuse lung cysts in LAM. Neurofibromatosis has variable thoracic manifestations ranging from ribbon ribs to rib notching, neurofibromas, which can occur in the skin, but also intercostal and mediastinal. The pulmonary diseases that we see are really quite rare when it comes to neurofibromatosis. But approximately of those that do manifest a pulmonary disease, about 25% of them will show a cystic abnormality. More commonly, we see upper lung predominant bullae with some lower lung fibrosis, but sometimes we do see just pulmonary cysts instead. So in this case, we see small, discrete, thin-walled cysts. They're slightly lower lung predominant in this particular case, although I'm not showing you the craniocaudal plane. But the key in this particular case was the associated finding of a neurofibroma occurring along the posterior mediastinum near the inner margin of the rib adjacent to the vertebral body. So in this case, you'd be hard-pressed to distinguish the cysts from a mild LIP or distinguishing it from a mild case of LAM. But you can see, based off the associated findings, maybe that rib notching or other neurofibromas that are occurring, that would lead you to the diagnosis of neurofibromatosis. Protein deposition diseases also cause cystic lung disease. Two primary forms of the protein deposition diseases to discuss, first one being amyloid, which is Congo red positive, and the other one being light chain deposition disease, which would classically be Congo red negative. Both are clinically similar, with a very high association with multiply myeloma or macroglobulinemia, high association with renal failure, and overall they have very high mortality for both of them. The cysts that form tend to form as a result of airway narrowing with a ball valve effect because of the infiltration and protein deposition from the amyloid or from the light chain deposition. That can also lead to alveolar wall destruction due to ischemia from vascular infiltration or flat out disruption of the alveolar walls due to amyloid deposition. Now, the amyloid itself can present in a variety of different ways. So most commonly, that's a simple solitary pulmonary nodule that manifests in a majority of amyloid cases. Calcification in amyloid occurs very frequently. You can end up also with areas of interlobular septal thickening, sometimes with variable degrees of fibrosis as evidenced by honeycombing, or sometimes you end up with more subtle ground glass abnormality. Lymphadenopathy is fairly common, and you can also end up with tracheal amyloidosis, which leads to tracheal wall thickening that does not spare the posterior membrane. Lung cysts can be seen as well, and again, that's why we bring it up in this context. But the lung cysts in at least a certain percentage of patients will actually turn out to be related to LIP in a decent percentage of patients. Now, light chain deposition disease can also present with nodules and lymphadenopathy, but the cysts in light chain deposition disease tend to be more discrete, and you see less of the other associated findings like you do in amyloid. So here's a case. We see a lot of nodules, but notice surrounding all of those nodules is this unusual looking cystic abnormality that is probably due to some pretty severe desmoplastic reaction and alveolar wall destruction surrounding these pulmonary nodules. I don't show it to you on these views, but several of these nodules demonstrated some abnormal areas of calcification. So this is, again, not a pure cystic abnormality for a lot of this, although there are in the right lower lobe some actual bizarre looking cysts. But this cystic abnormality is fairly unique looking, and when you see this, you should definitely think of amyloid because you do not see abnormality that looks quite like this very frequently in other cases of nodules or cysts. So here's another one where we see more interlobular septal thickening and more diffuse ground glass, but again with some lower lung predominant cysts as well, thin-walled cysts. And again, even in some of those areas where we have this nodular consolidation, we're seeing this unusual cystic abnormality surrounding those. And here's yet another case where it looks more like an interlobular septal case of amyloid, where we see some lower lung interstitial abnormality, reticular abnormality, and some subtle ground glass with, you know, some architectural distortion. But even here in the left lower lobe, we see again one of those more discrete nodules with this abnormal cystic abnormality surrounding it. Again, that's a pretty unique look that I'd have never seen outside of amyloid. Contrast that with light chain deposition disease. So in this particular case, again, we're not seeing the same abnormality that we were seeing in amyloid, but again, a nice, clean, discrete lower lung predominant cystic abnormality. So here, lower lung distribution slightly. Compare that with the more diffuse distribution that you would see in a case of LAM. And that brings us to cystic metastasis. And cystic metastasis is kind of a difficult one to evaluate for. You really need an appropriate history of a primary malignancy to suggest this diagnosis. Most frequently, it's epithelial origin, but you can have some mesenchymal ones, leiomyosarcoma, angiosarcoma, synovial cell sarcomas that lead to this. And when I say cystic metastasis, I mean true cystic metastasis, not cavitating metastasis that started off as nodules and then cavitated like you might see in relatively common squamous cell carcinomas and so forth. I mean metastasis that manifest primarily as a cystic abnormality. So here's an example of one. So these are discrete cysts. If we follow these over time, they were not nodules that cavitated and left cysts behind. These were discrete cysts that always looked like this and progressively enlarged as true cysts over time. Now in cystic metastasis, because this is a malignancy, these are randomly distributed just like other hematogenic metastases are. Because of that, you will find some distributed throughout the lung parenchyma and frequently in a subpleural distribution, and those have a very high tendency, unfortunately, to rupture into the pleural space, leading to pneumothorax, as we saw in this patient. So this patient ended up with bilateral pneumothoraces during a single hospital stay due to treat their underlying cystic metastases, and these were caused by an angiosarcoma metastasizing to the lung, leading to cystic metastases. So in summary, lymphangioliomyomatosis, think of the sporadic form as premenopausal women, exclusively, essentially. There's also the tuberous sclerosis complex related form that can occur in men as well. But as far as the cystic lung disease, they are diffusely distributed, uniform, clean, pristine looking cysts. Remember the other associated findings: chyloseffusions, chylosocieties, renal angiomyolipomas, but the angiomyolipomas can occur anywhere in the body. It's just very common to see them in the kidneys. PLCH, highly associated with smoking, greater than 95% of the time. Now remember, early in the disease course, it's not actually a cystic lung disease. It presents as upper lung predominant central-lobular nodules with lower lung costophrenic angle sparing, right middle lobe and lingular tip sparing. But as the disease progresses and those central-lobular nodules cavitate, they progress to these bizarre looking cysts. And those two diseases are ones that you really, really want to be able to distinguish between. So LAM has those diffuse, uniform looking cysts, but PLCH has those upper lung predominant, bizarre looking cysts. And I find it useful to remember that in PLCH, the cysts came from cavitating nodules. And that helps to remind me that that's why they're bizarre looking, because originally there were nodules that progressively cavitated and became cysts over time. LIP, rare compared to the other two diseases, highly associated with Sjogren's disease, and idiopathic disease is extremely rare. Those cysts, although individually can look like the cysts seen in LAM, the ones seen in LIP tend to be lower lung predominant with a perivascular distribution that we don't see in LAM. Remember, these other more rare diseases or more rare causes of cystic lung disease, neurofibromatosis, look for the skin lesions, look for neurofibromas as the clue to those cysts in those cases. And remember Birt-Hogg-de-Bay, because it has some clinical features that, at least on paper, seem similar to lymphangioliomyomatosis with skin lesions, but the skin lesions in Birt-Hogg-de-Bay are due to fibrofolliculomas instead of adenomosovation. Then the cysts are lower lung predominant instead of diffuse. And they also have a subpleural and paramediastinal relationship that we do not see in LAM. And instead of angiomyolipomas like we see in LAM, we see renal cell carcinomas and oncocytomas in Birt-Hogg-de-Bay. The protein deposition diseases can also give us cystic lung disease, especially on the amyloid side. It may more commonly present with nodules, but you can see that somewhat unique looking cystic abnormality. And cystic malignancy is always something to kind of hold in your background of your mind, but that's a very hard one to prospectively diagnose if you don't have a history of malignancy. I'll point out these references. Each one is a great review article with additional examples, because I think especially with diagnosing diffuse cystic lung disease, the more examples you see of these things, the better. So each one of these are good articles for you to follow up and read. And with that, I'll take any questions.